So I just put the slides up on Learning Suite, so it'll be on Learning Suite. Does anyone have any questions? No.
What are the answers?
To the test?
Yeah.
I don't know. So I have looked at last semester's test, and he said he'll change about 25% of it, so just so you know. Okay, so we're going to talk about inflammation first. So it's an important part of tissue adaptation and healing. Make sure you know the difference between what inflammation is and the cardinal signs of inflammation. So usually people say, oh, inflammation is swelling, it's heat, it's redness. Those are the signs of inflammation. So the definition of inflammation is the presence of immune cells in the tissue and the presence of chemical and inflammatory mediators. And that leads to the cardinal signs of inflammation, which is swelling, heat, redness, pain, and loss of function. And you guys can actually go to the Learning Suite and download the PowerPoint if you want to, so you can like write in the notes section, so you don't have to worry about writing all this stuff out if you want, just a suggestion. Okay, so the roles of inflammation are to get rid of dead cells, also called necrotic cells, and to initiate repair, so that you can get ready for the healing process. So stem cells. Stem cells are basically like the umbrella cells, right? They can become anything. The two that you need to know are lymphoid stem cells and myeloid progenitors. So lymphoid stem cells are important for our adaptive immune system, and myeloid progenitors are important for our innate immune system. What's the difference between our innate immune system and adaptive immune system?
Innate you're born with it, adaptive you get over time.
Yeah, pretty much just the definition of the word. So innate, your body's born with it, and adaptive, maybe it's foreign to your body, but when your body receives it, then it will adapt and create a response.
So lymphoids for adaptive?
Yes. And then the big players for inflammation are neutrophils, monocytes, and macrophages, and they come from myeloid progenitors.
So, sorry, lymphoid is innate and myeloid isn't.
No, lymphoid is adaptive,
That's what
and myeloid is innate. And neutrophils, monocytes, and macrophages all come from myeloid progenitors. So know the differences between acute and chronic inflammation. So acute comes on really fast. The main player are neutrophils. Usually mild injury, and the symptoms are prominent, so it'll occur like that. And then chronic inflammation takes a longer time to progress. It's mostly going to be monocytes, macrophages, and lymphocytes. There's going to be severe tissue injury that leads to fibrosis, and we'll talk about that in a little bit, and less prominent symptoms just because it takes a while to progress and it's there for a longer time. So chronic inflammation is the result of inadequate healing and overuse of the muscle. And I think you guys talked about this in class. There's M1 macrophages and M2 macrophages. So M1 macrophages, that's the cell of chronic inflammation because they're pro-inflammatory and it's part of the degenerative phase. And M2 macrophages are responsible for immune suppression and tissue repair, so it's part of the regenerative phase. So if you have chronic inflammation, there's a ton of M1 macrophages that are pro-inflammatory and just breaking stuff down, and not a lot of M2 macrophages because it doesn't fix things. So that's why it's inflamed over a longer period of time. And then Also, if healing doesn't go well, like if M2 macrophages don't do their job, then it can lead to fibrosis, which is scar tissue. So that's a fast, quick way to patch up injuries, but it causes greater risk for re-injury because it's not full healing. So know the steps of acute inflammation. First, there's injury, right? And then damaged cells release chemical mediators and immune cells detect cell death. So if you remember his picture, they send out chemical mediators, and then there's vascular changes. So there's going to be vasodilation, an increase in permeability, and activation of endothelial cells, which all lead to swelling, right? So things are going to get bigger, more fluid's going to come in, and the injured area is going to swell. And then will be the infiltration of neutrophils, and that lasts about 24 hours. They're responsible for the removal of debris, and they signal for the next phase, which is macrophage and monocyte infiltration. And that signals regeneration, which is the M2. So the graph of cell activity versus days, I'm going to draw it on this board. So you'll have cell activity, and then days, right, so like 1, 2, 3. So what's first?
Neutrophil.
Yeah, neutrophil. So that's going to come up, and it's going to peak around 1 day, and it'll go down. So this is neutrophils. And then next is macrophages M1. So it's going to come up like this. And the peak is going to be around 2 to 3 days, and then it'll go down. So this is M1. And then M2 is like further out, lasts longer. Okay. So be able to draw this, explain it, recognize it, label it.
Did you say that M1 peaks at day 2 or after day 2?
So M1 is like day 2, day 3. I think it's more towards day 3.
Yeah.
Okay. So chemical mediators are important because if you inhibit them, then you'll have a decrease in inflammation. So NSAIDs, other drugs, they block the production of inflammatory mediators, which is not always good because inflammation is part of the healing process. As far as the table goes, I would know like an example to know what histamines are, what they do, prostaglandins, something like that. He's not gonna like have you fill out the table, but he might ask you for an example or something. So. Okay, chemokines. So this is a signaling cell, and it helps guide leukocytes to the injury. And leukocytes is just another word for neutrophils. So leukocytes are going to arrive by chemotaxis, which chemokines are going to be more concentrated at the area of injury, and so leukocytes will look for the concentration, and they'll follow the concentration until where it's most heavily concentrated, and that is the process of chemotaxis. So following the concentration of chemokines to the site of injury. Okay, does anyone have a question about inflammation? No? Okay. We're going to go on to muscle. So just know the basic structure of skeletal muscle. There's a muscle fiber. A group of muscle fibers makes fascicle, which is surrounded by endomysium. Then fascicles bundle together. They're covered by perimysium. And then it's muscle, that makes muscle covered by epimysium, you have the tendon, bone. It's not too in depth, you'd be able to label a picture. Okay, the force velocity curve of a muscle. So, you need to be able to understand this graph, also be able to draw it, be able to explain it, things like that. Basically, in this class, anytime there's a graph, just be able to draw it. So this is just saying that speed of muscle contraction influences force production. So with concentric exercises, the faster the contraction, the less force production. And with eccentric, the faster the contraction, more force production. And eccentric forces produce the most injury. So I was kind of explaining this to the earlier class, and I might have confused them. But this is velocity equals 0. So on both sides, velocity is increasing this way. So this is not like decreasing velocity. It's technically negative velocity, but it's increasing in magnitude. And so just know that this is increasing velocity. So increasing velocity, more force produced. Increasing velocity on this side, less force produced. Does that make sense?
So it's technically the faster it's going eccentrically, then the higher the force.
Yeah.
But the slower it's moving concentrically, the higher the force.
Yes.
Okay.
So when you think about like a bicep curl, right? You don't want to like pump it really fast because more force will be produced if you go slower, so it'll work your muscle more. And then when you like extend, you want to do it slowly and not like whip it down, otherwise it might cause some problems.
Do it faster. It's more force. That's why the injury happens.
Okay, so satellite cells are muscle stem cells that are activated during regeneration of the muscle. So when they're activated, they proliferate, migrate, differentiate, and they fuse to muscle fiber. And we'll talk about what they do in the muscle healing process in a couple slides. Okay, muscle strains happen close to where the muscle fiber ends, and eccentric forces cause muscle strains because there's a lot of force produced. Okay, muscle strain grades. So know the difference in grades. Be able to list characteristics, be able to compare them, be able to match them, I don't know. So grade 1, stretched fibers, movements painful, but you have a full range of motion still. Grade 2, there's torn fibers, contractions painful, and then grade 3 is the worst, where the muscle's actually ruptured, there's significant impairment and a great deal of pain. And these are going to be similar to ligament strains. Strain grades, it's basically like worse, well I guess they're all bad, but the worst, less worse, and then
Isn't 2 the most common one that happens?
usually in grades, usually 2 is the one that happens most. Yes, 2 is the second. With ankle sprains, grade 2 is the one that's most common. Okay, so know the skeletal muscle healing timeline as well. So day 2, the acute inflammatory response and hematoma, basically just signaling. Day 3, that's when satellite cells are activated. Day 5, satellite cells fuse to muscle fibers. Day 7, regenerating muscle cells extend to a scar. Day 14, scars condense. Day 21, interlacing myofibers fuse with connective tissue. So on the first exam, you had to like list out the RTP, be able to do that for this as well. Basically any timeline, be able to write it down. And then skeletal muscle healing, it builds from the outside in. So I think there's a picture that goes along in the slides with the healing timeline. For those of you who like to picture things, it can kind of make sense. contusion is caused by compressive force and it leads to muscle cell death. It can also lead to myositis ossificans, which is when muscle turns to bone, and ecchymosis, which is bruising. So we'll talk about this later when we talk about treating muscle contusions, but you're not going to want to compress a contusion, right? Because it's already compressed. So you want to elevate it, make sure that's not swollen, stuff like that. Just know how to apply rice. We'll talk about that. Okay, we're getting into stuff in the readings. So it talks about DOMS, which is delayed onset muscle soreness, and it's caused by overtraining undertrained muscles. So know what that stands for and how it's caused. And then they talk about different treatment methods. So anti-inflammatory drugs, a lot of people say that it's detrimental to the healing process, but in the reading it actually says that it's not. So anti-inflammatory drugs are detrimental to the inflammation process, but to the overall healing process, there's no evidence that it's detrimental. So make sure you distinguish those two. So anti-inflammatory drugs inhibit inflammation, so it's not good for the inflammatory process, but for the overall healing process of muscles, the study said that there's no evidence that it's detrimental to the healing process. Like people will say that, oh, if you take NSAIDs, then your muscle won't heal all the way, or something like that. But the reading said there's not really a ton of evidence that says that.
Is that referring to all muscle injuries? Or just contusions?
No, that's muscle injury. All muscle injury. Okay. They also talked about ultrasounds, and it says that there's no evidence that it's effective.
In relation to
Muscle injury.
So why do they do
Okay, so then there's RICE. So know what RICE stands for: rest, ice, compression, elevation. That he talked about this in class. So for rest, there needs to be 2 to 3 days of rest. In the paper, it says that physical inactivity is important. Ice isn't really that effective for muscle injuries. It might help reduce pain, but it's not really effective for healing. Don't compress muscles. Elevation helps with swelling. And then it talks about how there's evidence that it's effective, but there aren't any actual trials, like clinical trials, that proves its effectiveness or validates it. So a lot of people have used it, obviously, but there haven't been any like specific scientific trials that have validated its effectiveness. So RICE applies to different types of injuries, so know when it's effective and not effective for like muscle injuries and sprain, ankle sprains and stuff like that, yeah.
So if ice isn't as effective for muscle injuries, what is it more effective for?
Is ankle injuries.
So like more ligaments or?
Basically, ice is like gonna help with pain. It's just gonna help reduce pain. That's the main purpose of ice.
And compression, right?
Compression.
That's one of the things. So why not compression? Because I feel like in our taping lab we do a lot of like compression wraps and stuff like that.
For muscle injuries?
Yeah.
So I don't know, it said in the paper, and he said in class, like, don't compress it just because usually that's how the muscle is injured. And so if there's a lot of inflammation, then you're not going to want to compress the inflammation, you want the swelling to go down.
Okay.
Right? I think like muscle taping helps with like stabilization.
Okay.
And it does, so. Okay, so for return to play, it says in the study that Athletes need to be able to stretch the injured muscle as much as the healthy muscle, and they need a pain-free use of the injured muscle in basic movements before they go back to regular activity. So those are the 2 criteria. Okay. Bone. Does anyone have any questions about muscle? No. Going on to bone. So qualities of bone. It's changing. So you can lose bone mineral density really fast, and it takes a long time to get it back. So this is what we talked about when astronauts go to space. They lose their bone mineral density, and they come back, and it takes a really long time to get it back. It's the only tissue that can suffer severe damage and return back to equal or greater strength. It's composed of inorganic and organic material, and its functions is to support the body. And then long bones are strong and light. So just know the characteristics of bone. Okay, so cortical versus spongy bone. So know that cortical and compact bone are the same thing, and cancellous, trabecular, and spongy bone are the same thing. So in questions, like, I think you had a quiz question that was like, what type of bone is in whatever? And it said, compact, cortical, trabecular. You know that compact and cortical are the same thing, so if you didn't know the answer, then you should know that it was trabecular, right? Even if you have no idea what trabecular is. So just know that all of those are interchangeable, because it might throw you off on a test. So, cortical bone is dense. Spongy bone is more of a lattice filled with marrow. And cortical bone is in the shafts of long bones, spongy bones in vertebrae, flat bones at the end of long bones. Okay, this is the microstructure of bone. You don't need to know this too in depth, just know the different parts, maybe be able to label a picture. So you have the osteon, which is that, and then the different like rings in the osteon are lamellae, and then you have the lacuna, and inside an osteoblast, which makes it an osteocyte. Canaliculi are the little things coming out. And there's the central canal, also called the Haversian canal. You have nerves, arteries, veins running through that. That was all I need to know. That. Okay, so know the difference between bone cells. So osteocytes are osteoblasts in the lacunae. They respond to deformation, so they sense stress in the bone, that's their function. Osteoblasts build bone, so they line the surface of bones, and osteoclasts destroy. They're responsible for bone resorption. They have a ruffled edge that increases surface area for bone breakdown. In my opinion, they look like pattern. Okay, so indirect healing. Know the stages of indirect healing. Be able to write them out. So indirect healing involves transition tissues, so it doesn't form bone right away. Direct healing forms bone right away. Most often it's indirect healing. In fact, I don't know when direct healing occurs. He didn't really talk about that in class. So the first stage is hematoma. That's usually 3 to 4 days. Second stage is inflammation characterized by granulation tissue, and it's weak, so the bone needs to be immobilized. Third stage is soft callus stage. It lasts 2 to 3 weeks, and it's cartilage-like. The fourth stage is hard callus, more mineralization, lasts 6 to 8 weeks, and the bone is still immobilized. And then the fifth stage is remodeling, and it takes years. So know like the timeline, sorry, it doesn't last 6 to 8 weeks, it's like 6 to 8 weeks into the healing process. So at 2 to 3 weeks of the healing process, it's the 3rd stage, and then 6 to 8 weeks is the 4th stage. So for the bone to heal, it takes about 8 weeks, 6 to 8 weeks, but then for it to remodel, it takes years. And then Wolff's Law, I don't think the graduate guy went over this. It's the adaptation of tissue in response to loading. And so we'll talk about this a little bit later, but loading is important when you have an injury because otherwise your muscles will atrophy. And so loading can help build strength of the bone and maintain strength of muscle. And we talked about direct healing.
So direct healing is more with just osteoblasts, building it back up.
Okay, fracture management, talk about this in class. You mobilize it and transfer, and then surgery is used to set the bone back into place if there's a fracture or okay, tendons. So they're similar to muscle, parallel arrays of collagen fibers. They're really strong, double the strength of the muscle, reduce vasculature, so it's really hard to heal. Connects bone to muscle. There might be energy conservation, like it stores potential energy and gives it back to the muscle. And then the breaking point occurs after a 6 to 8% increase in length. So no characteristics of tendon, no the function of tendons. Okay, tendinosis and tendinitis. I don't know if you talked about this. So tendinitis is basically like the inflammation of it. To our class, he said that he didn't like tendinitis because he's like, tendon doesn't really get inflamed, so he goes more towards tendinosis, which is the degeneration of tendons. So it's characterized by disrupted collagen fibers caused by overuse and repetitive stress, and then it's tissue degeneration. So if you ever see tendinitis, it's like, it means the inflammation of, fasciitis is inflammation. But tendinosis is characterized by degeneration specifically. Okay, ligaments. So function of ligaments for elasticity, they're composed of mostly collagen, and then like I said before, the grade 1, 2, and 3 is pretty much similar to muscle. It's like if the ligament's stretched, if there's a partial tear, and it's just increasing pain. That's mostly the difference between the grades and ligaments. Okay, bones of the foot. So know what bones are in the forefoot, what bones are in the midfoot, and what bones are in the hindfoot. Metatarsals and phalanges in the forefoot, navicular, cuboid, and cuneiforms are in the midfoot, and the hindfoot is the calcaneus and talus. It's pretty easy. You can picture the breakup of the foot. It makes sense. Arches, you have your medial longitudinal and your lateral longitudinal and transverse. They provide shock absorption and help conserve energy. And arches will be important for some injuries that we'll talk about. Okay, so the ankle joint is the talocrural joint. It's between the tibia and the talus. It's the most mobile joint, the ankle, and plantar flexion and dorsiflexion occur there. And then there's the subtalar joint, talus and the calcaneus, and inversion and eversion occur there. So know what those look like, what makes up the joint, what motions occur there. Okay, and then the ligaments of the ankle joint. So there's the anterior talofibular. It prevents posterior movement of the fibula, which makes sense if you think about like where it's positioned. So the talus isn't going to move forward, and the fibula is not going to move back. It holds them together. Posterior talofibular prevents anterior movement of the fibula, right? It'll pull the fibula back, make sure it's going anteriorly. And then the calcaneofibular is kind of on the lateral, it's just on the lateral side, kind of runs like up and down, or used for stabilization. They all limit inversion. So when you have like a lateral ankle sprain and you invert, those are gonna get like torn. And then you have the anterior inferior tibiofibular, which that's injured from dorsiflexion. It's higher up. And the posterior inferior tibiofibular, when you injure that, it's a high ankle sprain. Okay, compartments of the leg. Know that there's anterior, posterior, and lateral. Most important is compartment syndrome. So probably know like what muscles are in the compartments, but I don't think he'll ask you too many questions about that. So compartment syndrome, it's compression to the muscular and neurovascular structures in the compartment. And symptoms, deep aching pain, tightness and swelling, and then don't compress it, obviously, because it's compression injury. Ice and elevation to help swelling go down, and if it's severe, then they'll have to get a fasciotomy. And if you want to be really grossed out, then you can look at pictures of fasciotomies.
Good stuff.
Okay, so these are injuries from the book that he told you to go over in the study guide, so this will be really helpful for you. So plantar fasciitis, it's depression of the longitudinal arches, both medial and lateral, and extension of the toes. So it talks about pes cavus, which is high arch, and pes planus, which is flat arch. So both of these things can lead to plantar fasciitis. So if you have a high arch, there's not enough movement, like it's high, so there's not going to be a lot of movement in the arch, and so when you extend your toes, it's going to be stretched, and then pes planus, there's too much movement because it's a flat arch, so your plantar fascia is going to be stretched. It's basically when your plantar fascia gets stretched. And symptoms, you're going to have pain in your arch and heel, especially during dorsiflexion. And then treatment, you can use orthotics, which is like an insert into your shoe so that you have more structure. It takes a while to heal. You can stretch it, massage it.
Right, so when you say depression of the, are you talking about like the action of the plantar fascia itself, or what's that depression of the longitudinal arches?
So just the longitudinal arches depressing, like flatter.
That's what happens when you have plantar fasciitis?
It's
You're saying
cause, so that's the cause.
That's the cause.
That's the cause of it, yeah. Is like depression of the longitudinal arches. So like people who wear just like regular shoes, like Vans, right? It's not really good structural support, and so your arch is going to depress. And so sometimes if you don't have strong arches, you'll have like a minor case of plantar fasciitis. I had it really bad on my mission because I walked everywhere and I had no structural support, so I keep her all the time.
Did it go back to normal after
Okay, a Jones fracture is the fracture of the fifth metatarsal. It's painful. It's really hard to heal because you don't put the bone in a cast. You can't really you guys can cast the foot, but you basically just stay off it until you have no pain. You're on crutches, and it's easy to re-injure. Okay, turf toe. This is great toe hyperextension, and it's a sprain of the metatarsophalangeal joint, so just between the metatarsal and the first phalange. Symptoms are gonna be pain, swelling, you can't push off, obviously, because that joint is injured. Treatment, get new shoes. That's what it says in the book. It says that like some companies have designed shoes with like steel in the bottom of them, or with soles that don't bend as much, so your foot's not, or your toes aren't extending as much. You can tape the toe, ice and ultrasound, and then obviously rest. Don't be running around on your hyperextended toe.
Question.
Yeah.
Just out of curiosity, what does ultrasound do for these injuries? Like, what do they think it does? Because when I hear ultrasound, I think imaging, but
No, so it sends like, I don't know, do you want to explain this? You're probably better at explaining it than I am.
It's just sending waves and it goes down into the muscle. And it's actually pretty much.
They say that the 2% of that wasn't effective.
Also true.
Or muscle effective.
But so they do it all the time with physical therapies, clinics with tendons and stuff, and it just sends waves or ultrasounds down into the body at different depths to be able to massage down to where you can massage in different body parts.
Phalange dislocation. So this is less common than fractures, but it usually occurs with a fracture. It's usually a dorsal dislocation of the middle phalanx proximal joint. So dorsal dislocation is going to be pushed up. Symptoms, intense pain, you can't move, obvious deformity, dislocated, there's going to be swelling. And then treatment is reduction. So reduction means you put it back in its place. It's not like reduction of activity or something. You reduce a dislocation, so you put it back into its place. And you'll learn more about this when you talk about upper extremity injuries, because you'll talk about shoulder dislocations. And you don't really cast the toes, there's this one. Okay, Achilles tendinosis and rupture. So tendinosis is stiffness and soreness. Those are going to be the symptoms, and thickening. It's just like irritation of the tendon. And then we talked about degeneration of the tendon. Treatment, ice, proper shoe wear. So like have good support and rest. And then Achilles rupture. It's caused by sudden pushing off action and extension of the tendon, right? Because it lengthens and it snaps. So it's going to snap, you're going to have a lot of pain, it's going to swell, you can't raise your toes. And then it occurs 2 to 6 centimeters proximal to insertion and needs surgery to heal it. It says in the book that there's also like the method of just taking anti-inflammatory drugs and like icing it and letting it heal itself, but they said that's just guessing. Yeah.
Yeah, well, I shadowed an orthopedic surgeon one time, and according to him, the Achilles tendon is the only one that doesn't need surgery. It'll actually go back together by itself.
It depends if it rolls up or not too.
Yeah.
Because if it doesn't roll up, then sometimes you can like cast it with the foot down and it'll go back together.
Yeah, so that's what it said, like
Yeah.
use
Yeah.
ice and casting. Okay, tibial stress fracture. So these are like tiny fractures, and it's basically caused by overuse. You're gonna have intense pain and point tenderness, and then you can, like he was talking about the bone percussion, it's not really a symptom. I don't know why I put it in there. It's mostly in treatment or like diagnosis. When you put like a vibrating rod next to it, then it'll cause intense pain. It's really hard to treat, but you basically just need to be on crutches until the pain goes away, stop activity. Okay, lateral ankle sprains. So we just talked about this. The medial malleolus allows instability, so you can invert and plantar flex. You can invert more than you can evert. So lateral ankle sprains are going to happen when you're supinating. So supination It's easy to think about it. It's your arch going away from the ground. And pronation is you're trying to push your arch to the ground. So supination, you're inverting and plantar flexing, so your arch is going up. Pronation, you're dorsiflexing and everting, so you're trying to push the inside, the medial arch to the ground. And that helped me a lot with understanding those. So lateral ankle sprains affect the ligaments, like we talked about before. It's going to be your ATF, your PTF, and your CF. And then you have the different grades. So grade 1 is like an ankle roll, stretched but no torn ligaments, takes a couple days to recover. Grade 2 is the most common sprain, partial tear, swelling, bruising, takes weeks, a couple weeks to recover. And then grade 3 is a complete tear, loss of function, complete loss of function. Grade 2, there's a little bit of loss of function, but grade 3 is complete loss of function and takes 3 to 4 months to recover. So again, with the grades, with anything like grades or like healing processes, be able to list out each stage, list out characteristics of each stage, be able to compare characteristics of each stage. Okay, and then this you haven't talked about yet, but you should talk about it tomorrow, but I'll just include it in here. So risk factors, muscle strength, flexibility, proprioception, previous injury. So if you sprain your ankle, then you're 50 to 60% more likely to sprain your ankle again. Proprioception, if you don't have good balance, probably going to sprain your ankle a lot because you're going to be rolling around on it. And then muscle strength, flexibility.
So if you're less flexible, or if you're less flexible, you don't get a higher risk. Or is it more flexible, you get a higher risk?
You know, I'm not sure. You might want to ask me about that tomorrow. Because I could see it going.
Yeah.
And so it'd be opposite. So if your muscle strained, so if you're weak, then you have more risk factor than if you're stronger.
Yeah, and he'll go over this tomorrow, so if I teach you anything wrong, then know what he says is correct.
Do we have to know like any sort of like length of like the tendon or like the tendon stretch for it to be considered? Is that a part of like the grade 1, 2, and 3?
No, not part of the grades. We talked about, I don't know if you were here. So know that like Achilles ruptures occurs 2 to 6 centimeters proximal to insertion, and then for tendons, yeah, 6 to 8% increase in length is when tendons grow.
Okay.
But as far as like different grades, it's not like if it stretches 2 centimeters, then it's grade 1. Okay, so diagnosis for ankle sprains are easy. We do range of motion tests, obviously point tenderness, and then special tests you'll learn about tomorrow. It's the anterior drawer test. Basically hold their ankle and put your hand on the bottom of their foot, and you just move it forward. And if it moves forward, then you know that the ligaments are torn, and so like you shouldn't have that much motion in your foot. So that's the anterior drawer test. You'll also do that for like ACL, PCL, but you'll learn that later. And then the talar tilt is just like taking the ankle and inverting it, and there's going to be a lot of range of motion if those ligaments are torn. Though I don't know why they do these, because those would be super painful for the person, but whatever. Yeah, and you'll see pictures of those tomorrow. Okay, so diagnosis and treatment. So in order to know that there's a fracture, there's 3 rules. You can have bone tenderness along the fibula or lateral malleolus, bone tenderness along tibia or medial malleolus, and the inability to bear weight. So it's usually like 2. You don't have to have all 3, but it's usually 2. So you either have bone tenderness along the fibula or lateral malleolus, tibia or medial malleolus, and then you're not going to want to bear weight if you have a fracture. So, for ankle sprains, rest is bad. So you need to mobilize it within limits of pain, and load bearing is good for regeneration unless there's a fracture, and obviously you don't want to put too much load on it, otherwise it can make the fracture worse. And then the rest of ice, so ice compression elevation is good because it limits fluid accumulation in the ankle. And then there's also other treatment methods. NSAIDs, you can use e-stim, surgery. Functional rehab is really important. Like we said, mobilizing it within the limits of pain. So you don't want to totally immobilize it just because, unless there's a fracture, because then there will start to be atrophy of muscles. And it will become weak. And then it will be more prone to re-injury. And then cryokinetics is ice therapy. So cold therapy helps reduce pain. And then balance training is important because if you get off like one of your ankles, then you'll have decreased proprioception, and so that also will increase the risk for another ankle sprain. So for chronic ankle instability, that's characterized by numerous ankle sprains, and the two things that lead to it are mechanical and functional instability. So mechanical is like degenerative changes. So breakdown in the actual structure of the ankle, and then functional is, like we talked about, impaired proprioception, impaired neuromuscular control, strength deficit. So you can't control your muscles or you're unbalanced. Those and degenerative changes, that's going to lead to chronic ankle instability. And you'll talk about that tomorrow. He should show you a graph. There's like a, what are those things called? It's like a circle.
Venn diagram.
Yes, Venn diagram that shows like you need both, and then it explains mechanical and functional instability. So that characterizes chronic instability. And that's it. So, if you don't have any other questions, then you're free to go. This PowerPoint will be online. It is online. So you can use that.